It's a pleasure now to introduce Richard Reilly, who is Professor of Neural Engineering in Trinity College, Dublin, and Director of the Trinity Centre for Bioengineering. Richard has been a very valuable member of the committee looking at how we can use modern engineering technology to help the aged population. And it's a great pleasure now to introduce Richard to give his talk. Richard.
Great. Thank you very much, George, and thank you very much to the Academy for allowing me to present on this section of the report looking at technologies. So all of us have our smart devices, our tablets, and we're all using Zoom today, as we've seen on the chats, many different people to be able to log in and view this particular webinar. Some of us may also have Fitbits and smart devices and smart watches, and all of these are fantastic facilitators to be able to promote healthy and active lifestyles. And they're also fantastic for promoting healthy and active aging. So they can help us with managing and monitoring our well-being. If they're configured correctly, that can be fantastic for assisting in activities of daily living. And also, if they're configured correctly in the home, can provide very safe and home environments for older individuals. The big drivers here, of course, are the miniaturization of the sensors. These things are getting smaller and smaller, integrated into so many different objects and devices. But also, one of the big drivers, of course, is the need to transform traditional ways we deliver healthcare. There's been some examples and some evidence from the literature of studies that have used what is called e-health or sometimes m-health, mobile health technologies. And these have shown some potential in terms of improving care, improving self-management, particularly looking at changing of behavior and also looking at adherence to medications. The reason why these are important, of course, from a clinical point of view, is that home-based technologies and wearables, that type of data that we get from sensors is very important to clinicians because it allows them to develop what's called integrated closed-loop care. And that really means that it allows them to form clinical pathophysiological phenotyping, or being able to classify different individuals, and particularly be able to spot certain changes in an individual's health, particularly at an early stage when interventions could have an impact. The same use of that type of data could also enhance therapies for different types of symptoms, which could be important. It would allow, as we've just heard from Professor Kenny, for tracking individuals longitudinally to be able to see if any impairments are cropping up, which allow also then some type of intervention that could take place. And it also allows subgroupings of patients to be targeted for certain treatments. But the evidence that we come across in our report is that we really need to aid healthcare professionals to learn and to upgrade their skills if they're going to use and incorporate technologies into daily practice for the benefit of older adults. Of course, one technology that we're using ourselves today, and many people are using it, has of course been telemedicine, or effectively video calls through Zoom and other means. Millions, as a result of COVID, have used video calls to talk to the doctors, and some of the statistics are incredibly interesting to look at. Just looking at the UK, before COVID, 10% of GP consultations were by video conference or telemedicine. That jumped to 75% during the peak of the pandemic. So while telemedicine or video calls is having its moment, the question is, really, will that moment continue, or will insurance companies continue to pay the large amounts of money that are required to be able to put these services into practice? We can see that the costs, by looking at colleagues in the States, in the period of March and April of this year, $4 billion was billed nationally in addition to federal funding just for telehealth services, and that compared to only $60 million for the 2 months last year. So huge amounts of money being involved here. But of course, telemedicine or video calls came to the rescue here for many people because of COVID, but unfortunately, that's not often the case. And some colleagues have just published an article just in July, colleagues from Cambridge, which showed that technologies which are geared towards healthy aging are very much haphazard. There's great opportunities, but in fact, the connectedness and the development of those technologies is really very underdeveloped. And the real problem here is that there's not enough clear concepts of what the overall goals are going to be, and also that technologies are not integrated sufficiently across the different levels of the healthcare service. One of the other issues, which has also come up quite recently as a result of COVID and published just this month or last month in Nature Medicine, is the increasing use of digital derived data, so from sensor data and other means, to be able to inform public policy around health. So this is an article from a colleagues in UCL in London who call for better regulation, evaluation, and use of digital technologies to strengthen healthcare management. So critically important as we go forward, learning from COVID in the last number of months. Of course, one of the challenges is how do healthcare workers use technologies and how can they embrace or change their work practices to deal with those? The NHS commissioned a report a couple of years ago, which was published earlier last year, which looked at the preparedness of healthcare workers to be able to deal with technologies. They had two recommendations. First was to get patients involved in the development of technologies. That was particularly important, particularly vulnerable groups, marginalized groups, to make sure equitability of access to healthcare services. And the second point, which is very important and often overlooked, is that healthcare workers need expertise, guidance, and also education to evaluate technologies, to see how they can be embedded into their normal practice. So if those two recommendations are fulfilled, their report from the NHS says that hopefully staff will gain more time and better interactions with the patients that they have. So the evidence really is there from our report also to show that healthcare professionals need to be involved in the design and evaluation of different technologies, particularly technologies which will be appropriate to older adults. And as a result, those technologies should allow doctors to be the doctors and to treat the person rather than treating the disease. Of course, all of the sensor data and all of this other data that might be coming in, do we really know more about the complexity of aging? And can we in some way change our focus to certain areas which may need attention and reduce our focus in others? Well, the evidence really isn't there that we found and what we reported in our SAPEA report. There are some healthcare models which have definitely shown benefit based on use of technologies. They tend to be for patients who have chronic diseases. Also, they tend to be very beneficial when the family members are incorporated into the care team. So helping to acquire that data, sharing it with the clinical staff. And the metric they've used in many of these studies is the reduction in the number of hospitalizations or the number of rehospitalizations that have taken place. Of course, there's a number of obstacles. The acceptance of technologies, not only by patients, but also by clinicians. Different economic models need to be developed. Interoperability across electronic health records has always been a challenge. And what Professor Kenny just mentioned a minute ago, it was access to the internet to be able to share that data with your primary care facilitator. That could often be a problem. So the evidence that we found and we report is that there's been no large-scale studies on home care which has been supported through the use of technology. So there really is a need to develop a strong evidence base which allows us to be able to develop solutions which are both scalable but also sustainable. There are, of course, some examples, which is great that we can look at. Here's a European example that was funded by the European Commission under the 7th Framework Programme from colleagues across Europe, published in The Lancet just late last year, looked at an interactive internet-based coach system for individuals, particularly older adults with cardiac risk factors. And their internet-based therapy did lead to modest improvement in risk profile for those particular patients. So the message seems to be clear that there are solutions, they just need to be scaled, and as a result, the overall reduction in the burden, in this case of cardiovascular disease, could actually be realized. Acceptance of technologies, of course, is critically important. We know that we only really use technologies when they're integrated into the normal activities of daily life that we get on with. And we also know that technologies for older adults are also critically important if they're involved also with their care providers, be they the formal care providers or informal care providers. Accessibility and privacy is an issue, as we've seen that today on the chat. Access to privacy and GDPR, of course, is very important, and we need to take more of a cognizance of those things. From the evidence we found, it tends to be more of a concern for clinicians and hospitals as it tends to be for patients. So patients are more willing to share the data in different forms. But I think that's going to become more difficult. And as we report in our document, as those sensors get smaller and smaller and start getting integrated into different types of devices, such as smart clothing, for example, then it's going to be much more difficult to know where and how consent has been given to be able to share that data. One of the other lessons we've learned also from COVID in the last number of months is that our rush to be able to develop contact tracing apps, and some of the calamities in different countries and states across Europe to do that, of course, is that we've neglected to prioritize data privacy. So that in some ways is a missed opportunity for digital health, that we in some way haven't shown the public that these devices can be trustworthy in different ways. And there's a report and comment on that in Nature Medicine just last week. Certification and regulation tends to be a huge issue as well. We have a very strong regulatory process in Europe for medical devices, but our Apple Watches and our smartphones, which have medical quality information that can be shared, are commercial devices. So at the moment, there are no regulatory procedures around the interface between your Apple Watch and interfacing with an electronic health record in a hospital, for example. So we need more attention in these areas. There are a number of different standard bodies across Europe and internationally looking at these things, and the European Commission itself, DG Connect, has been very focused in the last number of years also. We also know that electronic health records are not uniform across Europe in many ways. Patient privacy and confidentiality tends to be one of the problems and obstacles here. Where we store the data, is it locally in the hospital or the clinic, or is it nationally and in a centralized system, is also a problem. Legislation and different clinical practices across different states tends to be problematic. So a report highlights that there's evidence needed to generate some form of a minimum electronic health record, maybe an electronic medical chart that can be used across all member states, which provides minimum information about patient care and responsibilities and background information. Particularly important in terms of continuity of care as we go from one region to another, and particularly important also in terms of COVID, in terms of supporting public health programs. If we had that minimum electronic chart record, that may also have averted some of the problems that we've seen in the last number of months. One of the other issues that I think we'll be addressing for many years is how many people have passed away in COVID because data was not shared. Not because it wasn't able to be shared or willingness to be shared, but the interconnectability from a point of view didn't allow that data to be shared. So I think this is going to be something we're going to be looking at for some time. The availability of healthcare, we know across Europe is not uniform, particularly for advanced technologies. In some states, it tends to be based on a means process, a means tested process. In other states, it tends to come from a social care budget. So the evidence that we report is that it really needs to be a better method for evaluating and assessing the reimbursement of these new types of technologies. Of course, in Europe, we're not the only ones to be facing these types of challenges, and the US National Academy of Engineering produced a very interesting report last year looking at technologies addressing the challenges of aging. They came up with 4 recommendations: data sharing and doing so at scale, so very similar to what we've recommended, the need for standards for data integration, different disciplines involved in the evaluation and design of technologies, and different business models. So again, all focusing on the same challenges and hopefully pointing to the same types of solutions. So in summary, we have a huge number of devices which are providing quantitative measures of one's healthcare. So this is a huge resource to medicine, that we have these large volumes of data. That'll require different mathematical methods to be able to uncover subtleties in that data, to be able to predict changes in healthcare in the future. And as we've heard from Professor Kenny, if we're able to include data from individuals over the life course, over longitudinal times, that gives us a huge opportunity to be able to spot who may be more vulnerable in the future than others. We need certainly new business cases. How do we integrate technologies together is definitely needed. Of course, there'll be challenges. We'll have numbers of patients currently happening now, that people are coming to their outpatient clinics with printouts of their own medical records, or they're bringing their data in a USB stick. And of course, the challenge there is for the hospitals and hospital and medical staff is that data valid? Has their consent been given to share that data with the hospital? Is the data compatible with being able to be put on the electronic health record? So these are the challenges that we have to face. But of course, in every challenge, there's an opportunity. And the opportunity is that we can enhance home care, and we can also accelerate the patient journey through the acute hospital system if we can prescribe devices and applications. So as a result, we have more data before the person presents themselves at the hospital, which allows better clinical decisions to be made, and importantly then also maybe better acceleration through the hospital system. So we have shown in our report, and I think COVID in the last number of months has really borne this out as well, is that we need to focus on the essential things. And of course, the essential thing in healthcare is the individual. And I think technologies continue and will have an important role to play in this regard. So thank you very much.
Thank you very much, Richard. That's a perfect follow on from Rosa.